Thank you, Dr. Singh, for that wonderful introduction. And I'd like to say good morning, good afternoon, or good evening, depending upon what time zone you are joining us. We are delighted that you have joined us for the gastroenterology section of the Intensive Review of Internal Medicine. Our first speaker today is Dr. Anna Rutherford. She's the Clinical Director of Hepatology in the Division of Gastroenterology, Hepatology, and Endoscopy at Brigham and Women's Hospital, and an Assistant Professor of Medicine at Harvard Medical School. Her topic will be chronic liver disease and its complications. Welcome, Dr. Rutherford.
Great. Good morning, everybody. Thank you, Muthoka. I have no disclosures relevant to this presentation. What I would like to cover today is a little bit about the natural history and outcome of cirrhosis, the initial management of complications of cirrhosis, some updates and recent studies on management of complications of cirrhosis, and then appropriate timing of referral for liver transplantation. So the natural history of chronic liver disease, patients with different chronic liver diseases, viral hepatitis, non-alcoholic fatty liver disease, alcoholic liver disease. Over time, a proportion of these patients will develop cirrhosis. Compensated cirrhosis means someone has not had any complications, but as soon as someone develops a complication of cirrhosis, the most common ones being ascites, jaundice, encephalopathy, or variceal hemorrhage, they are called a decompensated cirrhotic, and a proportion of these patients will likely die from their liver disease. If you follow patients with a new diagnosis of cirrhosis over 10 years, nearly 60% of them will have an episode of decompensation. The most common way patients decompensate is with ascites, followed by jaundice, encephalopathy, or variceal bleeding. Some risk factors for hepatic decompensation include the following: GI bleeding, infection, alcohol intake, some medications, dehydration, constipation, obesity. In a study published in Hepatology in 2011, it showed that patients who were overweight or obese were 2 or 3 times more likely to have hepatic decompensation over a 5-year period. And surgery. Basically, these factors are all additional stressors on a cirrhotic liver. We worry a little bit about hepatic decompensation. We like to know if someone has had an episode of decompensation because we know that it substantially reduces survival. Here, curve A is a compensated cirrhotic, and their median survival is 9 years. As soon as this cirrhotic has had any type of hepatic decompensation, their median survival drops to 1.6 years. We'll come back to this a little bit later, but this decrease in survival is one of the things that we take into account when we're evaluating patients for liver transplantation. They must have decompensated cirrhotic because we know their life might be limited by their liver disease. We're pretty good at predicting survival in patients with cirrhosis. Here we have the MELD score, which is good at predicting 3-month survival in cirrhotics. It is an equation that includes a natural log of the bilirubin, INR, and creatinine. You can see that the INR is the most heavily weighted, the bilirubin is the least heavily weighted. And here is the MELD score against 3-month survival. In Region 1 in New England, we're transplanting patients with a MELD score between 30 and 40 typically. And as you can see, their median 3-month survival is really limited without liver transplantation, whereas a patient with a MELD score of 10 has a pretty good 3-month survival. We're also okay at predicting 1-year survival in cirrhotics. We use the Child Turco-Pugh score for this. This is an equation that gives points for encephalopathy, ascites, bilirubin, albumin, PT, INR. And based on a child's score, they're an A, B, or C, and this is linked with 1-year survival. So I'm going to start with the natural history of cirrhotic ascites, as this is the most common way patients decompensate. So a cirrhotic liver eventually will develop signs of portal hypertension when blood flow into the liver through the portal vein is impeded by the amount of scarring in the liver. Eventually, patients will develop uncomplicated ascites. A more progressive form of ascites includes hyponatremia, and then a proportion of patients will ultimately develop refractory ascites. So management of ascites, about 50% of compensated cirrhotics will develop ascites within 10 years of diagnosis. It's the most common complication of cirrhosis that leads to hospital admission. Any patient with new onset ascites requires a diagnostic paracentesis where a cell count is measured, a culture, as well as an ascites albumin and total protein. In appropriate situations, also cytology can be checked. Bleeding complications in a diagnostic paracentesis are really rare, even in therapeutic paracentesis, which uses a larger gauge needle. And the use of blood products, FFP and platelets, is not data supported. Despite this, many institutions require a certain cutoff for platelet counts and INR before performing a diagnostic or therapeutic paracentesis. There was a large study looking at over 1,000 patients who had platelets as low as 19,000, INRs as high as 8 or 9, and not one had a bleeding complication with the therapeutic paracentesis. However, different institutions have different guidelines. A serum ascites albumin gradient of greater than or equal to 1.1 is 97% accurate for portal hypertension, for a diagnosis of portal hypertension, and ascites related to that. So treatment options for cirrhotics with ascites. If patients are still using alcohol, cessation of alcohol can help considerably. The lighter blue colors were probably effective in 90% of patients. So a sodium-restricted diet, about 2 grams of sodium per day, and education about what that means. If a patient is hospitalized, involving nutrition is very important because most patients in the outpatient setting have no idea what a 2-gram sodium diet is. And the initiation of dual diuretics, spironolactone and furosemide, we recommend orally with single daily dosing, usually in the morning. Most patients, unless they're profoundly hyponatremic, do not need fluid restriction. The ratio that we like to use, which helps balance sodium and potassium, is a ratio of spironolactone 100 milligrams to furosemide 40 milligrams. And this can be increased every 3 to 5 days, depending on effect. Maximum doses of diuretics are spironolactone 400 milligrams and furosemide 160 milligrams. Cirrhotic patients don't like spironolactone because many develop tender gynecomastia. Amiloride can be substituted in doses of 10 to 40 milligrams for spironolactone in this situation. It's also important to think about whether you can stop NSAIDs, ACE inhibitors, angiotensin receptor blockers, and propranolol in patients with new ascites. These all can affect blood pressure, and these patients tend to have some vasodilation and hypotension that's linked to their overall mortality. Because this is a decompensating event in appropriate patients, this may be time to start a liver transplant evaluation, and we'll talk more about that later in the talk. There was an interesting study published in The Lancet in 2018 that showed in a European group weekly albumin infusions in patients with decompensated cirrhosis and ascites, not refractory ascites. These were patients who had ascites on moderate doses of diuretics, and they were given weekly albumin infusion. And this was shown to reduce mortality and also reduce complications such as hepatorenal syndrome, acute kidney injury, etc. This is not standard of care, but I think it has been a stimulus for some studies in the United States looking at weekly albumin infusion in these patients. So refractory ascites occurs in about 10% of cirrhotics who have ascites. The definition is ascites that's unresponsive to a 2-gram sodium diet and high doses of diuretics. So that's spironolactone 400 milligrams, furosemide 160 milligrams, or clinically significant complications of diuretics. So patients who develop encephalopathy, elevated creatinine, hyponatremia, or hyperkalemia. Options for these patients include serial large volume paracenteses or TIPS, and consideration of liver transplant referral in appropriate patients. And any patient undergoing large volume paracentesis of at least 5 liters should be given albumin infusion of 6 to 8 grams per liter removed. This has been shown to improve survival and prevent what's called post-paracentesis circulatory dysfunction. This is really large volume paracentesis without albumin repletion is a trigger for acute kidney injury and hepatorenal syndrome. The use of non-selective beta blockers in patients with refractory ascites has conflicting data. We do think it's important to reduce or discontinue non-selective beta blockers of patients who have a systolic blood pressure less than 90 millimeters of mercury, or if they are admitted with acute kidney injury. So this is a study published a while ago now looking at the 4 large-scale randomized controlled trials of TIPS versus large volume paracenteses for refractory ascites. As you can see, studies in cirrhotics or decompensated cirrhotics, large scale, are pretty small still. And what you can see is that in all of the studies, TIPS did better at controlling the ascites, but it wasn't a 100% sure fix. The success rate of TIPS for controlling refractory ascites was anywhere from 51% to 79%. There was no difference in survival in any of the studies. And as you might expect, patients who received TIPS were more likely to have hepatic encephalopathy than patients who are getting large volume paracenteses. So in patients who have not had a history of encephalopathy before, TIPS is a really good consideration for management of refractory ascites and prevents patients from coming into the hospital 1 or 2 times a week for large volume paracenteses and albumin infusion. So moving on, and this I will say early in my liver training was something that I found hard to sort of wrap my brain around. We covered refractory ascites, and actually hepatorenal syndrome is a continuum of this spectrum of emergence of ascites in cirrhotics. So the clinical features of hepatorenal syndrome, you must have both cirrhosis and ascites. Your creatinine must be greater than 1.5 milligrams per deciliter with no improvement after 2 days of diuretic withdrawal. No improvement after volume expansion with albumin, giving 1 gram of albumin per kilogram of weight up to 100 grams. There can be no evidence of shock or nephrotoxins, and if there is a sediment, it must be bland with no parenchymal kidney disease. So the natural history of hepatorenal syndrome is the following. Patients with type 2 hepatorenal syndrome, their major issue is really refractory ascites. These are patients who have an elevated creatinine, so they can't necessarily receive diuretics. So they're getting frequent therapeutic paracenteses. This is hence the spectrum that hepatorenal syndrome follows. For these patients with type 2 hepatorenal syndrome, there's usually some insult. Major insults include an infection such as spontaneous bacterial peritonitis, GI bleeding where there's a hypotensive episode, or some other surgery or something that causes an insult to the kidneys. And here you see a very rapid rise in creatinine and oliguria, and the patients develop the dreaded type 1 hepatorenal syndrome. The median survival of patients with type 2 hepatorenal syndrome is about 6 months. The median survival without liver transplantation of type 1 hepatorenal syndrome is less than a month. So management of hepatorenal syndrome, treatment of the underlying liver disease, patients who have alcoholic hepatitis and cirrhosis related to hepatitis B, if they are treated, and this is successful, this can prevent hepatorenal syndrome. And anyone admitted with spontaneous bacterial peritonitis, again, which is a major trigger for transition from type 2 hepatorenal syndrome to type 1 hepatorenal syndrome, these patients, we should be thinking about their kidneys and giving them albumin infusion and cessation of non-selective beta blockers. There's a lot of data to support both of these things. When we're pretty sure that someone has type 1 hepatorenal syndrome, the initiation of albumin, octreotide, and midodrine to help perfuse the kidneys is data supported. If the patients are in the ICU, we recommend norepinephrine or vasopressin in addition to albumin. Terlipressin, which is being used in Canada and Europe, is very effective in treating hepatorenal syndrome. It's not yet approved in the United States. Patients who are considered liver transplant candidates can be stabilized with type 1 hepatorenal syndrome with hemodialysis in hopes of liver recovery or eventual transplant. There is some data for TIPS in patients with type 1 hepatorenal syndrome, but the numbers are limited. And liver transplantation, obviously, in appropriate patients, given the dismal survival with both type 2 and type 1 hepatorenal syndrome, should be considered. So a few words now on spontaneous bacterial peritonitis, which we discussed can happen in anyone with ascites and is probably the #1 trigger for patients developing type 1 hepatorenal syndrome. So a few words on that. Patients admitted with community-acquired SBP should receive systemic antibiotics, ceftriaxone or cefotaxime, avoiding aminoglycosides, again, because of the concern for kidney dysfunction in these patients. Most patients will respond to a 5-day course of treatment. If patients are clinically improving, there's no need to do a repeat paracentesis. If patients are not improving, then it is important to make sure that this is the correct antibiotic and they are responding. Again, data to support stopping non-selective beta blockers to protect the kidneys primarily. And albumin is recommended in patients with any of the following: elevated BUN or creatinine or a serum bilirubin greater than 4. This is given at 1.5 grams per kilogram on day 1 and 1 gram per kilogram on day 3, again, to prevent the development of type 1 hepatorenal syndrome. Get a lot of questions about prophylaxis of SBP, both primary and secondary. Anyone who's a child's B or C cirrhotic who is hospitalized with any type of GI bleeding should be given IV ceftriaxone or IV antibiotics. Any cirrhotic who has an ascites total protein of less than 1 gram per deciliter who's hospitalized for something other than GI bleeding should receive primary prophylaxis. Primary prophylaxis is also recommended in any cirrhotic who has an ascites total protein of less than 1.5 grams per deciliter and either renal failure defined by the following: creatinine, BUN, or sodium, or liver failure. So they have a child score of at least 9 or a bilirubin over 3. Secondary prophylaxis is important. Anyone who's had a prior history of SBP should be on secondary prophylaxis. We tend to prefer trimethoprim sulfa, 1 double-strength tablet daily, or ciprofloxacin, 500 milligrams daily. There are studies looking at weekly doses of antibiotics, and they may be as effective as daily doses of antibiotics for primary or secondary prophylaxis, though there are some concerns about resistance and patients forgetting to take antibiotics if they're taking them once per week. So moving on to hepatic encephalopathy, another decompensating event. Most important really is to figure out what has caused hepatic encephalopathy and treat that. The most common reasons patients come into the hospital with encephalopathy include infection, electrolyte abnormalities, particularly sodium abnormalities, potassium abnormalities, and acidosis. Any type of GI bleeding, constipation and dehydration, and patients who are taking sedatives. The goal is really to lower the ammonia level, which is what is causing the hepatic encephalopathy. We recommend starting with lactulose, aiming for 2 to 4 bowel movements daily, and then transitioning to rifaximin, which is probably better tolerated and more effective in patients with acute hepatic encephalopathy. There's no need to follow blood ammonia levels in these patients. They may vary from what you find on physical exam, but really relying on a physical exam and a neurologic exam to determine if patients are still encephalopathic. There's also no indication to randomly check an ammonia level in asymptomatic patients. This can lead to concern because it may be elevated, and then you may be wondering whether you should be starting your patient on lactulose. Another important thing, which actually goes against what I learned when I was in medical school, is you should not restrict protein in any decompensated cirrhotics. Decompensated cirrhotics are undergoing a catabolic process. It's important to maintain a dietary protein intake of 1.2 grams to 1.5 grams per kilogram of weight per day. There's no good data to say that a high protein meal is a precipitant for hepatic encephalopathy. So moving on to gastroesophageal varices. These are present in about 50% of cirrhotics, 30 to 40% of compensated cirrhotics, and 85% of decompensated cirrhotics. In compensated cirrhotics, varices develop at a rate of 7 to 8% per year, hence our need to continually survey these patients every 2 to 3 years. Patients who have a liver stiffness of less than 20 kilopascals on elastography or a platelet count over 150,000 are very unlikely to have gastroesophageal varices. That being said, anyone with a new diagnosis of cirrhosis should undergo an endoscopy to screen for gastroesophageal varices. There's no varices on the original endoscopy. It's recommended that this is repeated every 2 years with ongoing liver injury. This means in patients who remain overweight and their cirrhosis is due to non-alcoholic fatty liver disease, or they're continuing to use alcohol, or 3 years if patients are thought to have less risk of ongoing liver injury. They have been abstaining from alcohol, or they have been cured of viral hepatitis B or C. If you find small varices, grade 1 varices on the original endoscopy, it's recommended to repeat the endoscopy every 1 to 2 years. And if someone decompensates, meaning they have their first onset of ascites or encephalopathy, this is another time to consider an endoscopy. The general idea is that their portal pressures have probably gone up and they're probably more at risk of having esophageal varices. The patient has cirrhosis but no varices. There's no data to support putting them on medication to prevent varices. You really want to prevent their clinical decompensation, so counseling them on alcohol cessation, weight loss, etc. They have grade 1 varices. It's recommended to start them on a non-selective beta blocker. Grade 2 to 3 varices, you can consider a non-selective beta blocker or variceal ligation, but generally not both. Often more anxiety-provoking is acute bleeding in cirrhotics. And this really depends, the management of this really depends on the location of the bleeding, the severity, and the degree of hemostatic impairment. It's also important to figure out what kind of bleeding it is. For patients who have variceal bleeding, the major driver of this is increased portal pressures rather than a bleeding diathesis. The bleeding diathesis certainly doesn't help, but the main driver is increased portal pressure, and our goal in treatment should be really lowering this. For non-variceal bleeding, patients who have a peptic ulcer or diverticular bleed, this is when we focus on the bleeding issues related to cirrhosis, managing the INR, the platelet count, and the fibrinogen level. These patients should all receive vitamin K, usually IV for 3 days. Try to get their platelet count over 50,000, and ensuring that the fibrinogen level is between over 100 to 120 milligrams per deciliter, either with FFP or cryoprecipitate. In severe bleeding cases, also considering an antifibrinolytic, such as aminocaproic acid. Thrombopoietin receptor agonists are now approved for use in cirrhotics to prevent bleeding, but they are not effective in acute bleeding because they usually take 5 to 7 days to have an effect on platelet count. So management of acute variceal hemorrhage, these patients should be admitted to the intensive care unit, and guidelines suggest an upper endoscopy within 12 hours. There's good data to support a restrictive blood volume resuscitation. So initiating blood transfusions at a hemoglobin of 7 and maintaining a hemoglobin between 7 and 9. This has been shown to reduce rebleeding as well as reduce overall mortality. These patients should be given short-term antibiotic prophylaxis, IV, if they're coming in with acute variceal hemorrhage. They should also be on a vasoactive medication to lower portal pressures. Again, portal hypertension is the driving force in acute variceal hemorrhage. So octreotide, somatostatin, or terlipressin, and then ultimately transitioning these patients to a non-selective beta blocker. There is good data to support considering a TIPS, even if the initial variceal bleed is controlled with band ligation. Patients who are child C cirrhotics or child B with active bleeding, and there are some studies supporting proceeding with TIPS, which reduces the risk of rebleeding and actually increases overall survival quite substantially. There was a study in hepatology in 2019, referring back to the original study in the New England Journal of Medicine in 2010, that described this TIPS and these management in these patients. And it's really showing that centers are not very comfortable with putting patients through TIPS unless they're having life-threatening bleeding. They are not using it as a prophylaxis in these patients, despite evidence that it is beneficial. So just to review what a TIPS is, it stands for transjugular intrahepatic portosystemic shunt. It is placed through the internal jugular vein down into one of the branches of the hepatic vein. It is a shunt that is pushed through the liver until there's connection with one of the branches of the portal vein. The idea is to reduce, to allow more smooth blood flow through the liver, as opposed to blood being impeded by the cirrhotic liver and having a backflow into the branches of the portal vein. So management of bleeding gastric varices. So the same thing, these are a sort of special phenomenon and often somewhat concerning. Vasoactive drugs, restrictive transfusion, and antibiotic prophylaxis are all recommended in either esophageal or gastric variceal bleeding. Banding gastric varices can be technically quite difficult, particularly the further away they get from the GE junction. Patients who have varices in the fundus or the antrum, these are very difficult to manage because they're very large. Things that we can use are cyanoacrylate glue injection, where you basically inject this glue through a needle right into the varix. It polymerizes into a firm clot. There is a risk of distal embolization. It's actually not FDA approved for use in the US and requires center-dependent expertise. TIPS is a good option for patients with bleeding gastric varices. There's also several procedures that are more isolated and focused on managing gastric varices. One is a balloon-occluded retrograde obliteration. This relies on the fact that patients with gastric varices often have a spontaneous gastrorenal shunt. A catheter is placed into and through this shunt, and there's an right into the gastric varus, and they instill a sclerostin or a sponge. This has been shown to have 90% long-term bleeding control, managing that specific varix that has been bleeding. But interestingly, because you close a spontaneous gastrorenal shunt, it can actually increase portal pressure in other locations. So it can worsen esophageal varices if patients have those, and also cause ascites. The key to the BRTO is you really want to use it in patients with isolated gastric varices, because if you're not sure if they're bleeding from esophageal or gastric varices, then closing this shunt can certainly trigger or make their risk of bleeding from esophageal varices bigger. There are also centers that are using endoscopic ultrasound-guided transesophageal coiling of gastric varices, which is extremely effective. So moving on to optimal timing of referral for liver transplantation. The recommended time is when someone has had a clinical decompensation as well as a biochemical decompensation, or a MELD score of at least 15. As we review, the most common ways patients decompensate are encephalopathy, ascites, variceal hemorrhage, hepatocellular carcinoma, hepatorenal syndrome, or hepatopulmonary syndrome or portopulmonary hypertension. Other considerations of patients who need to be transplanted are if they have acute liver failure or poor quality of life or recurrent or resistant infections in primary sclerosing cholangitis and polycystic liver disease. What is the MELD score? It stands for the Model for End-Stage Liver Disease. It was originally created to predict short-term mortality post-TIPS. It's been the basis for liver allocation in the US since 2002. And since 2016, we've been using the MELD sodium. So there are 4 objective lab tests: the sodium, the total bilirubin, the creatinine or INR. As I showed you earlier, this is highly predictive of 3-month mortality in cirrhotics. And the reason we use a MELD score of 15 is this is the threshold where patients survive longer with a transplant than without a transplant. Patients with MELD scores in the teens, in the single digits, are likely to survive longer without a liver transplant. So if you look at the etiology of adult transplant recipients in the United States, a large component of these are patients who have hepatitis C. A large component of these patients have malignancy, and then there's others. Around the last couple of years, with our ability to cure hepatitis C and the United States getting more and more overweight and developing metabolic syndrome, non-alcoholic fatty liver disease has supplanted hepatitis C as the #1 indication for liver transplantation. Malignancy here is hepatocellular carcinoma, and hepatitis C and non-alcoholic fatty liver disease are two of the main underlying etiologies of liver disease of patients with hepatocellular carcinoma. Exclusions for transplant include a MELD score of less than 15 because there's no survival benefit. And basically, patients have to have a very sick liver but an otherwise healthy body, so they cannot have severe cardiac or pulmonary disease unless it's related to their liver disease. They can have HIV infection but not AIDS. Any ongoing alcohol or illicit substance abuse, HCC with metastatic spread, uncontrolled sepsis, an anatomic abnormality that precludes transplant, intrahepatic cholangiocarcinoma, any extrahepatic malignancy unless it's very remote with a very low risk of recurrence. Probably the reason that we decline most patients for transplant is persistent noncompliance or lack of an adequate social support syndrome, in addition to ongoing alcohol or illicit substance abuse. Living donor transplant, this is about 6% of liver transplants in the US each year, 4 to 6%. Patients must be listed for deceased donor transplant, so they have to undergo the same screening and qualify for a deceased donor transplant. These are patients who have an anticipated prolonged time on the wait list. They have to have a MELD of at least 15, but they're usually less sick because they're only receiving 2/3 of a liver as opposed to a full liver. So MELDs of 15 to 20 are really ideal. Usually it's a family member or acquaintance with close relationship and no coercion. The only thing they have to match, somewhat have to match on size, but also blood type. In adults, we take the right lobe of the liver, 2/3 of the mass of the liver about, from the donor and give it to the recipient. Pediatric cases can use the left lobe in a living donor transplant. And if you look at a map of the United States, UNOS divided the United States up into 11 regions. If you're listed for a transplant, you're listed within your region. You could also be listed in other regions as well, but a liver becomes available from a donor in a region for a recipient within that region, typically first. As you can see, these regions were divided up in the 1980s when liver transplant was starting to be used. There's marked variability in numbers of transplants per year, which is why in regions such as Region 1, where we have the second least number of liver transplants available, and patients who are sick, we will often refer them to other regions, such as Region 3, where there's just markedly more numbers of liver offers. This has implications for how sick patients are who are on the transplant list, and mortality of patients who die before they get a liver because they are waiting. Their MELD score has to be very, very high in order for them to receive a liver. So in summary, hepatic decompensation reduces survival. MELD and child Turco-Pugh scores predict 3-month and 1-year mortality in hospitalized cirrhotics. Consider tips in patients as well as large volume paracentesis in management of refractory ascites, particularly if they haven't had encephalopathy before. Prevention of HRS includes antibiotics and upper GI bleeding, IV albumin in patients with SBP or undergoing large volume paracentesis. There's good data to support non-selective beta blocker cessation in SBP. Gastric varices are their own thing, and they're a little bit more complicated to manage than esophageal varices, but we can use cyanoacrylate glue, TIPS, BRTO, or EUS coiling. And the time to refer for transplant is with a MELD score of at least 15 and any signs of clinical decompensation.
We'll go with one of your questions. We'll do one of your questions, and then in the interest of time, we'll address the questions online in the Q&A session at the end. Thank you so much.
Thank you. So I'm going to start with my first question. A 61-year-old patient with cirrhosis from hepatitis C is admitted with abdominal pain and confusion. His admission creatinine is 2.1, and he has evidence of SBP on his TAP. In addition to starting ceftriaxone, your next steps in management should include all except A, stop nadolol, B, albumin infusion 1.5 grams per kilogram, check your analysis, or D, start pentoxifylline. Still looks like people are voting. Okay, should we? So the correct answer is D, which it looks like the majority of patients got. This cirrhotic man has what appears to be acute kidney injury in the setting of spontaneous bacterial peritonitis. A urinalysis is recommended to evaluate the acute kidney injury, which could be hepatorenal syndrome or something else. In SBP, there is data to support cessation of non-selective beta blockers while the infection is being treated, as well as giving albumin infusion to prevent HRS on the first day of treatment. There's no data to support the use of pentoxifylline in cirrhotics with acute kidney injury or SBP.